Good afternoon, and welcome to Grand Rounds today. Today I have the pleasure of actually reintroducing Jeff Wall, who has previously presented several times at Grand Rounds, and those presentations have been so uniformly excellent, we keep pestering him to come back. By way of introduction, he received his Doctor of Pharmacy degree from Idaho State, holds more positions right now than I probably have time to review, but they include being professor of pharmacy practice and professor of clinical sciences at Drake. He's a director of the Drake University Drug Information Center, adjuvant clinical associate professor of medicine at the University of Iowa, and internal medicine pharmacist at Iowa Methodist Unity Point. And we're very appreciative of the fact that he kindly accepted our invitation today to again provide us with an update on Gamechangers in medicine. And please join me in welcoming Jeff Wall.
All right, thank you. Oh, again, everyone, usually my voice is so loud I don't even need a microphone, but hopefully everyone can hear me. Welcome. Many of you have been here before and kind of know the drill, but what I try to do with these is give everyone kind of a rapid update in some of the latest things that it's going to affect internal medicine practice. And since I'm a pharmacist, they do tend to be more in the pharmacotherapy realm. But we do try to look at things like guidelines and new studies and new drugs and FDA stuff and on all that kind of stuff that hopefully will allow you to really immediately use this information at the bedside is really what we're trying to do here. So here are my disclosures. I will be using off-label medication, talk about off-label medications, some learning objectives, and again, we got a lot of slides to go through, so I won't dwell on a lot of this stuff. But I mean, bottom line is that I'm hoping that whether this is a trial, a new drug, a new set of guidelines, anything practicable, again, you can really turn around in the next couple of days, and the next time you see a patient who has that problem or issue, you can kind of apply these game changers to them and hopefully improve outcomes for your patient. So as you guys know, game changers are things that directly impact pharmacists or physicians. Some of them are really specific, IV drug shortages, an oral blockbuster drug goes generic, and then others are more general in scope, a landmark study, new guidelines, stuff like that. And so like I said, because of time, we're just going to run right into the first game changer. So the first game changer is the 2023 GOLD guidelines for the treatment of COPD. As you guys are well aware, COPD incidence is still climbing, even though the overall incidence of smoking has leveled off. We've actually started to see an increase again in the incidence of COPD. And that's because it isn't just smoking, though that's, of course, the most important thing, but, of course, gene and other environmental factors over one's lifetime that can lead to obstructive lung disease. And then when you add that to, again, not just smoking, but polluted air, occupational exposures to dusts and fumes, they can all lead to chronic inflammation in the airways, which then leads to obstructive lung disease, and some of the physiologic abnormalities of that. You get mucus hypersecretion with chronic bronchitis, you get ciliary dysfunction with chronic bronchitis, but you also get gas exchange abnormalities and emphysema, et cetera, et cetera. So the GOLD guidelines are released every November or so by the Global Obstructive Lung Disease Group, and they are, no pun intended, the gold standard for the treatment of COPD. And there's some significant changes in 2023's guidelines compared to previous guidelines, and probably the one big one is listed in these boxes below. A few years ago, the GOLD group decided to have this kind of complex matrix where you kind of determine what stage COPD somebody was in based on how many exacerbations they had, what their FEV1 was, and what their symptom scores was. And I think they've kind of minimized that a little bit and made things a little bit easier with the 2023 guidelines, which are here on the right. So instead of A, B, C, D anymore, now we just have 3 sets of guidelines. So basically, if somebody has no exacerbations and their symptom scores pretty decently, they're in stage A COPD, and a bronchodilator is the initial treatment of choice. If they have a higher symptom score but low levels of exacerbations, that's stage B, which the opening therapy should be a LABA and a LAMA, which again is still, that isn't new to the guidelines. See, in 2022 is the guidelines too, but I'm still running into a lot of not right, resistance isn't the right word, but people think that we should start with an ICS LABA, and really it's LABA/LAMA in patients with stage B COPD. And then if they have greater than 2 exacerbations or greater than 1 leading to hospitalization, no matter what their symptom score, there wasn't before. Now there's just a stage E COPD where LABA/LAMAs again are the baseline of therapy, and you should consider inhaled corticosteroids. If you believe they have type 2 COPD, which is an eosinophilic COPD, much more likely to have an effect with inhaled corticosteroids. And the guidelines say basically an eosinophils of a blood eosinophil count of greater than 300 is really where you're looking at that. So here's kind of a nicer way to phrase that basically is, again, group A should be a bronchodilator. It doesn't really matter which one, a SAMA or a SABA would be reasonable. Group B is where you're going to have symptoms or treatment for maintenance symptoms, and that's, again, always going to be a LABA and a LAMA. We know that LABAs or LAMAs increase FEV1, improve symptoms, and decrease exacerbations more than either drug by themselves. And then that should be the baseline of therapy if they have multiple exacerbations and considering adding inhaled corticosteroids in these patients. So now, why has there been this change about inhaled corticosteroids? Those more veteran physicians in the audience may remember how the pendulum has swung back and forth between the use of steroids and COPD. When I came out of school in the late 80s and early 90s, nobody used steroids for COPD because it's an obstructive lung disease. Why would we use steroids for them? Then the TORCH study was published that suggested that, yes, steroids are in fact beneficial. And then in the intervening time, we've had the WISDOM study and a couple other studies have suggested that no, not really, they're not beneficial, which really what tells us is that there's a subtype or a phenotype of COPD patients that inhaled corticosteroids are beneficial for. This has been termed type 2 COPD, and patients who have that we don't have a very specific or sensitive marker. The closest easy test we have is blood eosinophil count. If your blood eosinophil count is greater than 300, you're much more likely to benefit from inhaled corticosteroids than if you don't have that. So. They also talk about a number of factors leading to exacerbations, and the one I wanted to spend some time on because it's something that I think we just kind of give, in many cases, short shrift to, is inhaler technique. And I know I see a couple pharmacists in the audience. I think even pharmacists sometimes will kind of blow over this and say, well, it's pretty easy to learn. Here you go, and just kind of leave it at that. Certainly, there's other contributing factors, but I think that inhaler technique is something we can actually do something about, both at the physician point of care and the pharmacist point of care. This is extremely common. A meta-analysis done in 2017 suggested that overall error rates in using inhalers are approached 100%. And with metered dose inhalers, it's like 87%, and dry powder inhalers, it's about 61%. And you can argue, well, so what? I mean, obviously these drugs are still working, right? Because, they didn't give them any special way to give these drugs in the clinical studies, and they still found benefit. I guess that's true, but I would argue in any drug that's $200 to $400 a month, I would probably want to get as much bang for my buck out of that drug as I possibly could. And so we know that handling errors or can compromise drug delivery, and that leads to reduced efficacy. And again, given the costs involved and given the fact that exacerbations can be very expensive and can also permanently lower FEV1 in these patients, it makes sense to try and optimize as much as we possibly can inhaler use in these patients. So again, if you're a veteran like me, you remember that when the only game in town was metered dose inhalers, right? And they did a good job of directing a standardized dose of drug with a high dose pressurization pulse through the mouth. And the problem, of course, with metered dose inhalers has always been that they do too good of a job, that unless you use proper technique or use a spacer, that the vast majority of the drug impacts on the back of the throat and you end up swallowing it. And so most of the drug doesn't actually get into the lung. So I think that's one of the reasons why we've kind of gone away from metered dose inhalers. That FDA required inhaler companies to stop using chlorofluorocarbons and destroying the ozone back in the early 2000s is another reason why we've kind of gotten away. There are still some that are used, however, and again, as pharmacists and as physicians, I think we really need to make sure patients are using spacers with all of these. Dry powder inhalers really kind of took over from metered dose inhalers. One of the big advantages they have is that they have a high portability. They're usually pretty small, pretty easy to put in a purse or your pocket or something along those lines. The big problem with dry powder inhalers is that there is no propulsive technique in them. So basically, your ability to get this drug into the lower airfields is 100% dependent on your own inspiratory flow. And again, this is something that I think a lot of physicians are unaware about, that you need a minimum of 30 liters per minute of inspiratory flow to get the drug in the lower lung fields. If you don't have that, the drug is almost certainly going to concentrate mostly in the upper lung fields and it's not going to do anything. So I think that it is reasonable, and there's actually some very simple devices you can use for your clinic that are cheap, easy to get, that will allow you to measure peak inspiratory flow. And if somebody has severe COPD and has peak inspiratory flow below 30 liters a minute, they probably aren't a very good candidate for dry powder inhalers and maybe should be considered for something else. Kind of trying to find the Goldilocks of area between the meter dose inhalers and the dry powder inhalers or soft mist inhalers. So these basically do have a propulsive system where they deliver a fine mist that facilitates coordination. And so there is a delivery system, but it's much slower. And if you can breathe in correctly with actuation and inhalation, studies have suggested that even in patients with pretty poor peak inspiratory flow, you can get pretty good levels of drug into the lower lung fields. So soft mist inhalers may be the way we kind of go for a lot of things as time goes on. The big problem with them is that different assemblies are required for the different dry slow mist inhalers, and they probably more so than some other inhalers do require good coordination between actuation and inhalation. You got to make sure that you're able to easily push the button and breathe in as you're pushing the button, and some people have a hard time with that coordinative effect there, basically. And then, of course, nebulizers. It is important to note that for maintenance therapy and even for acute exacerbations of COPD, there is no evidence suggesting that nebulizers give you any better outcomes than plain old meter dose inhalers, but it's just kind of what we do in most hospitals. And of course, as many of the physicians are well aware, sometimes this is the only way to get patients the ability to afford their bronchodilators, because nebulizers are covered by Medicare Part B. However, they do require some coordination and your ability to understand the machine and how to use them correctly. And if there's any respiratory therapists in the audience, they will tell you that many times someone's brought in their nebulizer when someone's gotten really sick, and it's pretty disgusting because nobody's actually ever cleaned the thing in the years they've had it. So it definitely has its issues as well. So, some factors to consider when initiating ICS treatment. I was always kind of, even after the TORCH study was published, I have to admit I was a bit of a nihilist when it came to inhaled corticosteroids, because the TORCH study itself found that, yes, while you decreased hospitalizations for COPD when you used inhaled corticosteroids, you increased hospitalizations because of pneumonia. And so things kind of evened out. You really didn't actually decrease number of hospitalizations in patients. They just got admitted for a different reason. They got admitted for pneumonia instead of COPD. So I've always been a bit of a nihilist when it comes to these. But again, the factors that have been studied and what the GOLD guidelines recommend that strongly favor use is people who have multiple exacerbations, blood eosinophil counts of over 300. And certainly if somebody has a history of concomitant asthma, right? So they might have what's being called the COPD asthma overlap syndrome. There are people who have kind of phenotypic characteristics of both asthma and COPD. Then obviously inhaled corticosteroids should be used. We could do an entire another game changer on the fact that it is worth noting that for asthma, albuterol is gone. It should not be used at all for asthma, right? That in patients who have exacerbations of asthma, we should be going to SMART therapy, which is using formoterol and inhaled corticosteroids for acute symptoms, and that's in the latest GINA guidelines. But don't want to get too far in the weeds there, but that's something else that gobsmacks a lot of my attendings, because again, albuterol has just been the thing that we've used for 50 years, right, for acute symptoms. What favors use is blood eosinophils from 100 to 300, and then if blood eosinophils are less than 100 and they have repeated pneumonia events, you probably should not use inhaled corticosteroids for COPD. So, okay, that's terrific, but you've got patients, and I'm sure many of the physicians listening have patients who are already on double or triple therapy, and they're still having symptoms, right? So if they're having multiple exacerbations, despite the fact you have them on maximum inhaled therapy, what can you consider for them? The guidelines suggest that either roflumilast, and roflumilast is kind of a drug that was supposed to be son of theophylline. It was supposed to be kind of a kinder, gentler version of theophylline that wasn't so toxic. Unfortunately, it didn't really pan out that way, and it's also quite expensive. And so what I've seen my pulmonologist do, and what certainly I recommend, is if you have somebody on maximal inhaled therapy and they're still having exacerbations, it's probably time to go to daily azithromycin in those patients. And remember that we're using azithromycin there not as an antibiotic, but as an anti-inflammatory. We're using mostly for its anti-inflammatory effects. So that's Game Changer 1. A lot of information, right? Game Changer 2 is 2 new studies on diuretic use. The quote I have of this is, what we used to thought we know just ain't so. These are 2 studies that were done from the VA Pragmatic system that I think is really going to change up some of the old thoughts of how we use diuretics in patients. So first up, we're going to talk about thiazide diuretics. As we know, thiazide diuretics have long been one of the staples of use in treating hypertension. Again, I'm old enough to remember when the original All-Hat study came out in 2004 that pretty much put thiazides on the map. Remember that it was supposedly going to be the big study that determined which antihypertensive you should use first line in patients when they're first diagnosed with hypertension. It, of course, didn't do that, but what it did do is it suggested that thiazide diuretics were at least as good as ACE inhibitors and calcium channel blockers in decreasing hard outcomes, not just getting your numbers down, but decreasing cardiovascular events and progression of chronic kidney disease. And so, again, thiazides, have been used and should be used for that. But one of the things that experts noted was that in the All-Hat study, and in fact, all large outcome studies with thiazides, the hydrochlorothiazide was not the thiazide they used, it was chlorthalidone. And some had argued that chlorthalidone should be the preferred thiazide in hypertension because it has a longer half-life and is more potent, and that was the one that was studied in clinical trials. And so the big question in clinical circles had long been, if I'm going to start a thiazide in somebody, should I just pick chlorthalidone? Now, the reason hydrochlorothiazide is used so much, as all of us know, is that it comes commercially available with a whole bunch of other antihypertensives in one pill, so it makes things a little easier for patients. But if you're just going to pick a thiazide, why not chlorthalidone? Although retrospective studies had largely found no difference between the two. So the DCP study was the first study that the VA system is now doing, and it's a really kind of cool way to do these studies that no drug company is ever going to pay for a good randomized control trial on. And so basically the way the VA studies are set up is they're pragmatic randomized control trials. So instead of paying a lot of money for study coordinators and randomizers and follow, basically what they do is they say, okay, we have this interesting clinical question. We'd like to try and find the answer to it. And we're basically going to make all the investigators in the VA system, all the doctors in the VA system, investigators. And so we're going to put into the piece that we're looking for whatever, new drug, whatever change we want to take a look at, but it's going to be pragmatic. It's going to be at the level of dispensing. So rather than randomize a whole bunch of patients to X versus Y, we're just going to say, okay, in this case, we have a whole bunch of patients who are being seen in the VA system who are on hydrochlorothiazide for high blood pressure. Starting now, we're going to divide half of those and they're going to get chlorthalidone, and the other half are going to stay on hydrochlorothiazide. We're going to follow them over time and see what my outcomes are. And this is a really cool pragmatic design that is much cheaper, easy to do because of the electronic medical records the VAs have, and will allow us to answer a lot of these kind of nagging clinical questions that we've had for years and years and years. So in this study, they included people who were over age 65, had hypertension, a blood pressure of at least 120, and an active prescription for hydrochlorothiazide at a dose of 25 or 50. They then, as I said, split patients into 2 groups. They told patients who had been on hydrochlorothiazide in group 1 to say, okay, you're not taking that anymore. We're switching you over to chlorthalidone. And they estimated the dose conversion at 25 of 12.5 being chlorthalidone and 50 milligrams of hydrochlorothiazide being 25 of chlorthalidone, respectively. And then the other arm was just people who continued usual care. So that's it. Outcomes were first occurrence to a composite outcome, of a non-fatal cardiovascular disease or non-cancer related death in a time to event analysis. So we weren't just looking at were the numbers numbers better. Again, primarily they were looking at improvement in cardiovascular events as well as all-cause death. Secondary outcomes were just the individual components, and they did look at safety outcomes, including primary electrolyte abnormalities and acute kidney injury. Plenty of patients in the study, almost 14,000 patients were in the study, and what did they find? Absolutely no difference. So in looking at non-fatal adverse cardiovascular events, it was almost identical between hydrochlorothiazide and chlorthalidone, and the same with safety events, except that hypokalemia was statistically significantly higher with chlorthalidone compared to hydrochlorothiazide. Again, considering that chlorthalidone is a more potent thiazide diuretic, that just kind of makes sense. But bottom line was this large pragmatic study did not find a difference between hydrochlorothiazide and chlorthalidone in hypertension. Now, some of the criticisms of the study was that they did use a lower dose of chlorthalidone. The vast majority of patients were on 12.5, whereas in clinical practice we tend to use 25. Had they used the higher dose, would they have found a difference? And because of that, there really wasn't that much of a difference in blood pressure between groups as well. The study also only went on for about 3 years, and some have argued, was that long enough to show a difference in cardiovascular outcomes between the two studies? But bottom line is this was a pretty good study, pretty well done, and it seems like you should just pick your poison for thiazide, so it seems. The other interesting study that followed this exact same pragmatic design was the Transform-HF study. As we all know, Lasix by far is the most commonly used loop diuretic for heart failure. But as I've taught students for years, Lasix isn't a very good drug orally. Remember that the bioavailability of oral furosemide is only about 30%. And the thought was always when somebody started to develop symptoms of heart failure, not only did their legs get full of fluid and their lungs get full of fluid, but their gut got full of fluid too, and they would stop absorbing a drug that already had pretty poor bioavailability to begin with. Torsemide and bumetanide, the other two big loop diuretics on the market, have much higher bioavailabilities, and so many experts in heart failure would preferentially use those two drugs to furosemide on the theory that you would still get good diuresis in patients even if they started getting fluid retention. There were some small studies that suggested that this was in fact true, but no modern randomized control trial data had looked at that. So again, the exact same thing. This is a pragmatic RCT by the VA in this pretty much exact same design where they had a whole bunch of patients on furosemide and then they split them and said, okay, half of you are going to go to torsemide at the same dose, half are you going to stay on furosemide. So the inclusion criteria included that they had to have had a CHF exacerbation, they had to have HFrEF, they had to have an EF of less than 40% within 24 months prior to. They also had to have an elevated BNP during the index hospitalization, which isn't that really surprising, and a plan for daily loop diuretics upon discharge. They did exclude patients on dialysis or transplant patients, and again, they were randomized to a treatment strategy of torsemide or furosemide prior to hospital discharge with the dose and frequency of that therapy based on the treating clinician. So again, pretty much the exact same design of the study. This was a little bit different in the DCP study in that it was an event-driven study. So instead of looking at number of patients, they kept going until they had a number of events that would show a difference between them if one existed. This study was designed to go until there was 721 primary events, which ended up being about 6,000 patients. That outcome was all-cause mortality assessed in a time-to-event analysis. So you got to give these guys credit for swinging for the fences, because there is no more powerful outcome than mortality, right? And then they had numerous secondary outcomes as well, hospitalizations, et cetera, et cetera. So they had about 2.5-year follow-up. Mean age of the participants was 65. Baseline beta blocker use at time of admission was 81%. ACE or ARB use or ARNI use was 67.5%. Surprisingly for the VA, 1/4 of the patients were on Entresto. Knowing how hard it is to get Entresto in the VA system, I have to admit I'm pretty surprised by that number. Spironolactone patients were 44%. And remember, this study came out before all the big studies that looked at how great SGLT2 drugs were for heart failure. So only 8% of patients were on SGLT2 drugs. But again, Nothing. They found no difference in patients who were discharged with furosemide compared to torsemide in any of the outcomes. This is the primary outcome of all-cause mortality. And again, you can see there's no difference, but no subgroup, no other outcome, and not even a difference when they looked at HFrEF versus patients who had elements of HFpEF as well. So bottom line was there was no difference between torsemide and furosemide in these patients. So a large pragmatic trial did not find a difference between torsemide and furosemide in heart failure. And I will admit mea culpa, because I've been recommending that for years. I've been recommending that for many, many years because it just made sense from a kinetic standpoint. But again, showing that sometimes kinetic differences don't always mean a difference in the real world. Some criticisms to this study was they did not reach their target of HFrEF, and if they had, maybe they would have seen a difference. As you might imagine, there was a high number of crossovers. Patients were on one and switched to another loop diuretic during the course of therapy. So bottom line, it seems just like for thiazides, pick your poison for most patients. And that's Game Changer 2. Game Changer 3, RSV vaccines, and since we're dealing mostly with adult internists in this room, we're going to focus on the adult use of RSV vaccines. So this is the prevention of headaches for patients, but causing headaches for the pharmacist who now has to do one more set of vaccines in the community setting. So those of you who've worked inpatient in the last year have probably noticed that we've really gotten beat up in adults this year with RSV, far more than I had seen in previous years. Maybe COVID had kind of crowded out RSV in the last 2 or 3 years, but bottom line is we'd absolutely seen a spike in severe patients with severe respiratory failure due to RSV. It is like all other viruses along these lines, respiratory viruses along these lines, a seasonal epidemic. It almost always occurs during the winter. And certainly if you have a small child, you've probably nursed them through a few RSV episodes and unfortunately may have had to take them to the hospital for RSV treatment. But in adults, it's usually pretty mild, usually mild or no symptoms. But like all respiratory viruses, the risk of being severely ill and requiring hospitalization goes up as patients get older, right? And so if they have more existing comorbidities, including age, this can lead to pneumonia and sometimes bad outcomes. And in fact, when you take a look at the data, it's pretty clear that among patients over age 65, the annual RSV burden includes up to 160,000 hospitalizations and up to 10,000 deaths. So again, it's for a virus that I think most of us just kind of blow off in patients who are adults. It actually is fairly serious and something we should think about. There are, just like with COVID, there's a number of chronic underlying medical conditions that put people at risk for hospitalization or death, and they're all the usual suspects, so I won't waste everybody's time going through each and every one of these. But again, the ones we tend to focus on are severely immunocompromised patients, patients with diabetes, patients with kidney or liver disorders. So in June 2023, CDC's Advisory Committee on Immunization Practices for the first time recommended the first of 2 new FDA-approved vaccines for RSV. And one is produced by GSK and the other is produced by Pfizer. The first is a recombinant fusion protein type of vaccine, and it's adjuvated, so they do use aluminum in it to help improve the immune response. That's pretty common with almost all vaccines. And so that's the RSV Pref V3, and that's, again, produced by GSK. And then there's the RSV Pref V, which does not have the adjuvant in it, but is just a recombinant perfusion F vaccine. Both are a one-dose series. As far as efficacy is concerned, with the GSK study, we now have 2 years of data with the GSK vaccine in patients at high risk. So this was a randomized, double-blind, placebo-controlled phase 3 study in 17 countries with 24,000 participants over 2 years, or 2 seasons, if you will. And they looked at vaccine efficacy, which they defined as a severe disease requiring hospitalization or death. So, I think what we usually expect is vaccine effectiveness. In season 1, vaccine effectiveness was 82.6%. So there was an 82% decreased risk of hospitalization or death in high-risk patients. In season 2, remember they didn't revaccinate, so this is just one dose. In season 2, the immunity had worn off some, so 56%. But if you combine the two, it was about 74%. And then the Pfizer vaccine, another randomized double-blind placebo-controlled study with about 38,000 patients. And again, they had a little bit broader definition, so they just didn't look at death or hospitalization. They just looked at lower respiratory tract diseases, so that you didn't necessarily have to be hospitalized or die from RSV, but you did need to be seen by either an emergency room or seek other medical care for that. And that probably explains why their numbers are a little bit better. So in their first season, they had about a 90% efficacy rate. Season 2 is about 78. But again, keeping in mind they had a broader outcome of what they considered serious. So I'm not sure you can say that the Pfizer vaccine is better than the GSK vaccine in preventing hospitalizations and death. Bottom line is they both seem to, at least in that first season, be pretty effective. Safety, which of course everybody is worried about now. There were 6 cases of inflammatory neurologic events reported in clinical trials. It is unknown at this time whether these were done by chance or with RSV vaccination increased the risk. They also found a small imbalance in number of atrial fib patients, and that was slightly nuanced. Atrial fib was slightly higher. Again, like so many other vaccines, I would argue that if you're at high risk, the benefit far outweighs the risk of these small chances of things happening. Again, no drug, no vaccine is perfect, and you always take a chance when you're meeting these, and you have to ask yourself, does the benefit outweigh the risk? So because of that, both AICP and CDC now recommend that in patients over age 60 may receive a single dose of RSV vaccine, and they don't say which one they recommend based on shared clinical decision making between themselves and their providers. Timing as far as the vaccine season, this kind of came late, and so they basically said, if you can do it in, this last season, that's reasonable, but that really didn't launch, and so we probably didn't see too many people who were vaccinated against RSV. Now I think we'll start this year with a large wave of people being offered vaccination, and they basically say to start in the summer. So go ahead and offer RSV vaccination as soon as the vaccine is available, and continue to offer vaccination throughout the RSV vaccine if someone is currently unvaccinated. You can co-administer with all other adult vaccines, including COVID and influenza, and if they're not administered on the same day, there's no required interval between vaccines. So some key points here, again, as if for my friends in community pharmacy, I do kind of feel bad for them because, again, here's yet another vaccine that's going to get thrown at them to take care of, and they're already completely overwhelmed. But the bottom line is that RSV can cause serious illness in older adults, and it's something I think we tend to forget about. Especially if you're at high risk. We have 2 now RSV licensed vaccines, and CDC and ACIPC, it is reasonable in patients over age 60 to consider getting a single dose of this. And that's Game Changer 3. Game Changer 4, corticosteroids for severe community-acquired pneumonia, or the Cape Cod study, which was published last year in the New England Journal of Medicine. So there are a few things that are more controversial, I think, than steroids in the ICU. Right? When someone gets admitted to the hospital with pneumonia, or respiratory failure, or septic shock with COPD, we've gone back and forth over the last 50 or 60 years about whether steroids are beneficial or whether they're not. Interestingly, the latest set of recommendations from the Society of Critical Care Medicine actually fall on the line of being very favorable towards steroid use, especially in septic shock, respiratory failure, or ARDS patients. But even in patients who don't meet those criteria, let's say they just have really, really bad community-acquired pneumonia, will steroids be beneficial? Up until recently, probably we didn't have a lot of good data one way or another. This is a meta-analysis that was published in the Annals of Internal Medicine back in 2015. Where they took a look at a whole bunch of other studies that had been published to that date. They looked at in the study, they looked at 12 trials of corticosteroids. And then some had the outcomes they were looking for. Not all of the studies had every single outcome. Median age was 60, and about 60% were male. In this meta-analysis of 12 trials, they did find that all-cause mortality, the risk reduction was 0.67, but unfortunately it passed 1, so it was not statistically significant. The need for mechanical ventilation, however, was a 65% relative risk reduction and was statistically significant. The developing of ARDS was also statistically significant with a relative risk reduction of 76%. Length of stay in the hospital was also statistically significantly lower in patients who got steroids. However, as you might imagine, the risk of hyperglycemia went up in patients who got steroids compared to those who didn't. Bottom line was that mortality change was not statistically significant, but going on needing mechanical ventilation was. But again, it points out that there's a whole bunch of small studies. We didn't really have an answer. And so now we have the Cape Cod study that I think is finally going to answer this question. This was a phase 3 multi-center double-blind randomized controlled trial that assigned patients who had been in the ICU for severe community-acquired pneumonia to receive intravenous hydrocortisone, 200 milligrams a day for either 4 to 8 days as determined by clinical improvement, following by a taper of 8 to 14 days, or to receive placebo. This study was done a little strangely in that a lot of the study was done in Europe, and they actually give steroids a little bit different than we do in the United States. They often give steroids by continuous infusion in Europe, and we don't tend to do that in the United States. All other patients received all other standard therapy, including antibiotics and supportive care. So in the study, 800 patients underwent randomization, 400 were assigned to hydrocortisone, and about 400 to placebo. So 400 were included the primary analysis, really basically in both groups. As far as the population is concerned, median age was 67. With about 70% of patients being male. About 22% of the patients had COPD, and about 24% of them had asthma. 44% of patients were already on mechanical ventilation or BiPAP, and that was split pretty much right down the middle. So invasive mechanical ventilation was about 23% between arms, and non-invasive was about 22% arms. And if they weren't on that, 42% of patients were on high flow. So basically between high flow, BiPAP, and patients who were ventilated, you're talking about 80% of the patients in this study. They did do the pulmonary severity index, which is a scoring system to determine who has severe and non-severe pneumonia. It's a nice idea, but it usually isn't done clinically. But bottom line, again, about 80% of patients had either class 4 or 5 community-acquired pneumonia, which is severe, associated with high mortality. Their mean SOFA score was 4, which is pretty high, and about 10% of patients in both arms were requiring vasopressors, usually norepinephrine in these patients as well. The intervention, again, as I said, was, again, this phase 3 study that looked at 200 milligrams hydrocortisone for 4 or 8 days. They basically made that determination on whether the patient was improving or not. After 4 days of therapy, if the patient had not had significant improvement in oxygenation and other signs of infection, they actually stopped therapy so they wouldn't expose patients to more steroids for no reason. But if they were improving, they got an 8 full days, and then they were determined whether they should be tapered for another 8 to 14 days after. Primary outcome was 28-day mortality, and the trial was actually stopped at the second interim analysis. What they found basically was it worked. That the hazard ratio for all-cause mortality did not differ, but the hazard ratio for mechanical ventilation did in fact differ between the two. And you can see the hazard ratio was 0.6, and that was statistically significant. So bottom line was, even though all-cause mortality did not decrease, patients who needed mechanical ventilation at baseline actually did decrease about 60%. Well, no, about 60% in these patients between hydrocortisone and placebo. And secondary use of vasopressors was similar as well. So you're much less likely to have to be on vasopressors if you were in the hydrocortisone group versus the placebo group. And number of patients discharged from the ICU also improved in patients who are on hydrocortisone versus placebo. So as far as safety outcomes are concerned, there was no difference in secondary infections. So ventilator pneumonia rate was similar between placebo and hydrocortisone, so was other bloodstream infections. In fact, the only difference between the two was an increased risk of hyperglycemia, which again, you would expect in patients on steroids. There was no difference in GI bleeding either, which was another big concern, that if we give people steroids, we're going to put them at risk for GI bleed. This is as good a time as any to note that steroids by themselves actually do not increase the risk of gastrointestinal hemorrhage. It's only when they're used in combination with nonsteroidals or anticoagulants. So it was a pretty decent study, good monitoring follow-up. Some weaknesses is they didn't really look at the treatment of pneumonia side of things, though they didn't collect, for example, was there an organism found, which organism? They also note that the observed mortality was lower than they targeted. They figured that 27% of patients with severe community-acquired pneumonia in the ICU would die when it was only about 12% of patients, so they lost some power there, and that's kind of worth noting. They also noted that only a small percentage of immunocompromised patients were in the study, and that should be applied cautiously to them. So that's game changer 5. Game changer 6, ketamine versus electroconvulsive therapy for non-psychotic treatment-resistant major depression, or in other words, is there anything at this point that ketamine can't do? So electroconvulsive therapy, as all of you know, is one of the most effective and rapid strategies for treatment-resistant major depression. It works very quickly. It's very effective even in patients who have failed multiple pharmacotherapies. And advancements in ECT, including administration while the patient's under brief general anesthesia, have enabled it to be used more commonly as an outpatient procedure. But unfortunately, it still is way underused due to limited availability, social stigma, and concerns regarding the adverse effects of cognitive impairment. Unfortunately, people have seen movies like One Flew Over the Cuckoo's Nest or a Requiem for a Dream, and they think this is what ECT is. This is not what ECT is. ECT isn't like this anymore. We do not torture people with ECT. We actually sedate them. The only real side effect at this point is that they have a little bit of retrograde amnesia around the procedure. That's it. So. Ketamine, of course, is an NMDA antagonist that was approved many, many years ago by the FDA as both a sedative, analgesic, and general anesthetic, but it's now being used in sub-anesthetic doses for all sorts of things, including pain and depression, as I said here, and a couple other things as well. If you come into the Methodist emergency room with a migraine or a kidney stone, odds are pretty good you're going to get ketamine in my emergency room. We have gone away from using opioids in those situations. So, and then some small studies did suggest that ketamine in single doses may improve acute depression. Now, it wasn't a sort of thing where you got a dose of ketamine and they were great forever, but in someone who was severely depressed, maybe suicidal, that a single or a couple of doses of ketamine seemed to dramatically improve mood in these patients, and their depression scores got a lot better. So somebody said, well, gee, if that's the case, maybe ketamine can be used in place of ECT. Obviously, it would be easier to give, probably doesn't have the social stigma involved with it. Maybe it can be used interchangeably. So this was a prospective, multi-center, open-label, randomized, non-inferiority trial that compared against small doses of intravenous ketamine with electroconvulsive therapy in patients who were adults with treatment-resistant depression, which meant that they had at least 2 inadequate trials to antidepressant treatment in their lifetime. There were 403 patients in the study, and they were assigned to receive 3 weeks of treatment with ketamine at 0.5 milligrams per kilogram of body weight over 40 minutes twice a week, or ECT 3 times per week. Now, of course, this wasn't a blinded study because that would have been pretty difficult to do. Their outcomes included a positive response to treatment, which they defined as an improvement of at least 50% in the score of the quick inventory of depressive symptomatology self-report systems. This is one of a dozen different types of scoring systems of patients' depression, but this is one of the more common ones that's used in studies. And so the quiz SR16 goes from 0 to 27, and really as you leave 15, 16, patients usually have very, very severe depression. They also looked at quality of life scores as well. This was a non-inferiority study. They were not trying to find that ketamine was superior, which I think was probably reasonable. Like most non-inferiority studies, what they did is they looked at a margin of error between the outcomes of the results of the two arms. In this case, a margin of negative 10 points. In other words, the percentage of patients with a response to ketamine would be no more than 10 percentage points less than the percentage of the patients who had a response to ECT. So, for example, if there was a 95% response to ECT, the patient could have an 86, the ketamine arm could have an 86% response, and it would still be considered non-inferior. That's not usually the way non-inferior studies are done. They usually use overlapping confidence intervals. I don't know why they didn't do that in the study, but they didn't, basically. So about 403 patients, as I mentioned, 200 assigned to ketamine, 200 to the ECT group. I apologize for this. For some reason, this didn't come up right when I was looking at the study, but I do want to just point out that the QID-SR score in this was 17. So again, remember, anything above 15 is considered severe depression. So by all measures, these patients had very, very severe depression. Over half of them also had general anxiety disorder on top of it, and they were on multiple medications to try and treat this. And what did they find? As far as quality of life, they actually found no difference in quality of life between ketamine and ECT. So again, they both seem to do okay there. Treatment response was actually superior with ketamine compared to ECT. 55.4% of patients had a 50% improvement in their depression symptoms compared to 41.2% in the ECT group. Now, in the trial, they kind of tout this saying, oh, now we know the ketamine's better. You really can't do that, right? They didn't do the studies to be set up as the superiority study. So I'm not sure I'm ready to run around saying ketamine is more effective than ECT, but I think we can safely say that ketamine seems to be at least as effective as ECT in treating acute severe depression. Adverse effects, the adverse effects, the ketamine group is the orange and the yellow, and then the blues is the ECT, the big one, muscle pain and weakness, was higher in the ECT group. Kind of stands to reason because it's ECT. But overall, adverse effects were very, very similar between the groups. So their conclusion was that among adults with treatment-resistant depression without psychosis, ketamine was non-inferior to ECT. Now, some experts have some issues with the study. One of the biggies was that more patients withdrew from the ECT group than the ketamine group, and that may have altered the results. The other is that apparently in this study, they did mostly right unilateral treatment, so they only applied one diode or cathode to one part of the brain, whereas apparently bilateral treatment is common as well, and they wonder if they had done bilateral treatment, they'd have gotten better. But bottom line was, I think the study shows that ketamine is an absolutely a reasonable alternative. Now the question is cost. No insurance company pays for ketamine, of course, but that is not. We have several people in Des Moines. I don't know about Ames. We have several people in Des Moines who are more than happy to give you 6 infusions of ketamine as long as you pay them $600 for each infusion. And those guys have a waiting list, I hear, of about 5 to 6 months. So lots of people want to try ketamine for depression. It's worth noting that maybe I'll be standing here next year, if you guys will let me come here next year. There's a current phase 3 study right now looking at microdosing of psychedelics for depression, and the initial data, the phase 2 data, is just unbelievably good. A single dose will provide lasting and sustaining improvement in mood for over 4 months. If that data is actually confirmed in a phase 3 study, that will absolutely and utterly completely change how we treat depression. So. Gamechangers 7, this was a big one. A lot of my internists were pretty surprised by some of the changes in the guidelines. So this is the 2024 American College of Gastroenterology guidelines on the treatment of alcoholic liver disease. Again, if you work in patient medicine, you see this all the time. Alcoholic liver disease is still pretty common worldwide. It's the leading cause of liver-related mortality in the U.S. Globally, 3 million people die annually to be attributed to harmful alcohol use, and it accounts for 5.3% of all deaths and 13.5% of deaths aged 20 to 39. Cirrhosis was the 11th leading cause of death in the United States, with half of those being due to alcohol. The COVID-19 pandemic has dramatically increased alcohol use disorder. And in fact, early studies now suggest that there's anywhere between a 14 to 20% rise in alcohol use during the pandemic and immediately after. And of course, that's going to lead to an increase in patients with cirrhosis and alcoholic liver disease mortality and transplant as well. So I think, the bottom line is this has always been a problem, but I think we're absolutely going to see a spike of alcohol-related cirrhosis in the next 5 to 10 years as a result of the pandemic. So based on that, the American College of Gastroenterology decided that they better come up with a new set of guidelines. This was your kind of standard set of guidelines where they invited experts from all over the areas of gastroenterology and hepatology and addiction medicine, and they got PICO questions, and then they used the randomized the evidence that exists to come up with answers to those PICO questions, basically. It would take an hour to go through all of these, so I just wanted to hit the highlights of things that are really, really different from previous guidelines. And this first one, I got to admit, this one completely surprised me. So now, in patients with compensated alcoholic liver disease, they recommend the use of baclofen over naltrexone as the strongest treatment option for alcohol use disorder. I have never used baclofen for alcoholic use disorder until these studies came out. So I was pretty surprised by that. Why? When you read the text, they note that baclofen actually has better data, especially in patients with mild to advanced liver disease, right? Because the problem with naltrexone is you can't use it in patients who already have significant liver disease, whereas baclofen you can. That being said, baclofen is cleared completely renally, and I've seen people get into real trouble with baclofen. So I would use high caution in patients who are on other CNS depressants, as well as patients with renal insufficiency. But they note in their review of the literature that it's been shown to safely reduce alcohol use in patients with alcoholic hepatitis and increase abstinence rates as well. The starting dose is 5 milligrams 3 times a day to a maximum dose of 15 3 times a day. I actually gave this a grand rounds of this at Methodist in February, and now to this point I already know several of my docs have switched, and they said so far so good. So withdrawal is something we deal with all the time. The guidelines say that in patients with alcoholic liver disorder and severe alcohol withdrawal syndromes, they recommend cautious use of benzodiazepines as treatment of choice and careful monitoring given their potential to precipitate or exacerbate hepatic encephalopathy. And then they do list numerous agents as adjuncts, but interestingly, not phenobarbital. Phenobarbital is kind of the flavor of the week, in my opinion, in the treatment of withdrawal symptoms. And I know there's some big proponents for it. Even in my own hospital, there are some people who believe that phenobarb is like the greatest drug in the universe with withdrawal syndromes. Again, maybe it's just because I'm an old man. I thought we invented benzodiazepines because phenobarb was too dangerous. I thought barbiturates were too dangerous, and that's why we invented benzodiazepines. So again, there's a big study. This VA pragmatic system, they're actually doing a study on phenobarb versus benzodiazepines. And certainly if that study comes out as positive, I will start recommending phenobarbital too, but not to this point. The other point that's worth noting too is that remember that we use the CWA score all the time in inpatients, and that's perfectly fine. But remember that there's some significant limitations to CWA scores, and probably one of the biggest ones is that in the original CWA study, they excluded patients who had bad enough agitation to be in the ICU. So if you have an ICU patient, you probably should not be using the CWA scoring system. We should probably do what we did in the old days, which was a scheduled taper of either lorazepam or oxazepam in those patients because we just don't have any data whether the CWA scoring is safe or efficacious. What about giving steroids for acute alcoholic hepatitis? Remember, the original MADRI study was done in the early 2000s that found that in patients with severe enough acute alcoholic hepatitis, 28 days of steroids decreased mortality. And they actually developed their own scoring system to determine whether you should use steroids or not. And that's the discriminant index function, or the MADRI score. They no longer recommend that. Why? Because it's a pain in the butt to do, because they use PT, prothrombin time, as one of the markers instead of INR, and nobody really uses PT anymore. We use INR. So the new guidelines recommending switching to the MELD score, which is commonly used. It has better accuracy. It's used to determine transplant status. It uses INR over prothrombin time. It also incorporates serum creatinine, which is a major determinant of outcome. So bottom line is MELD scores are easier to do and probably give us a better snapshot about whether patients are going to be in real trouble with alcoholic hepatitis. So with all that, the MADRI score is no longer recommended. You can just punch the patient's numbers into any calculator online that'll give you a MELD score. And if their MELD score is greater than 20, they do recommend corticosteroid therapy. So a MELD greater than 20 means steroids. Remember if they're going to use oral steroids, to use prednisolone and not prednisone, right? Because prednisone is a prodrug. It gets converted by the liver into prednisolone. So if your liver's shot, prednisone's probably not going to work all that well. If you're going to give them IV therapy, you can give them IV methylprednisolone, and that's perfectly fine too. At 7 days, at 7 days after starting therapy, you should consider doing something called a Lilly prediction score, which again is online and many online calculators. And you can punch the patient's numbers into that and see, are they seeing a good response to the steroids? If the answer is no, if their Lilly prediction score is low, you should probably stop steroids because they're probably not going to gain any benefit. And then the other big change, which again, I've not seen done and we're going to start doing, I guess, is that if you have a very high MELD scores of over 30, you should add intravenous N-acetylcysteine to steroids. So if you have somebody with a very, very high MELD score, it would not just be steroids, it would be steroids and IV N-acetylcysteine. Why do they recommend this? Because 2 large studies evaluated NAC as an adjuvant to prednisolone showed divergent results, but then a network meta-analysis compared the two and found actually that there was a significant decrease in survival at 28 days in patients who received NAC plus steroids compared to steroids alone. So bottom line is, because IV NAC is relatively harmless, and now it's much less expensive than it used to be, it's certainly reasonable to do. We just, at Unity Point, we just actually finished tweaking our NAC protocol for acetaminophen overdoses to kind of fit this a little bit better. So. And then finally, although it doesn't directly affect internal medicine physicians, it does note that selection for liver transplant in patients with alcoholic liver disease should not be based solely on an arbitrary duration of sobriety. So many transplant centers, for example, will say that you have to have demonstrated efficacy of sobriety or demonstrated evidence of sobriety for at least 6 months before you can get put on the transplant list. They note that there's no evidence to support that and that a comprehensive psychosocial evaluation should be done before making that determination. And then finally, running out of time here, obesity medicine update. As we know, we are now, for better or worse, in a golden age of drugs for treating obesity. This is a nice chart that takes a look at overall weight loss at 1 year with the different current therapies on the market. We still do have other things besides the GLP-1 drugs. You know, we do have phentermine and topiramate. We do have naltrexone and bupropion. And as you can see, you know, with the studies there, that especially with phentermine and topiramate, you can see about a 10% weight loss of total weight over 1 year. Not quite so good with that, or even liraglutide, but this is where the numbers really got crazy, right? So in the STEP studies, we found that the majority of patients lost anywhere between 15 and 20% of their body weight at 1 year. And Mounjaro or tirzepatide, which at the time this slide was done is not approved for obesity, had a 22% increase in weight loss. And so, you know, again, the GLP-1 drugs, as we all know, really changed the game when it comes to obesity, and have found numbers that are dramatically higher than therapy that was currently on the market. This is the STEP 1 study that took a look at and this was the first study that looked at semaglutide just in patients with obesity, and found that, you know, if you look at the bottom, what percentage of weight they lost, over almost everybody lost at least 5% of their weight, and a significant majority lost at least 10% of their weight. But even 1 out of every 3 patients lost more than 20% of their weight, with a mean weight at baseline of 230 pounds. This slide kind of takes a look at that as well. You know, it takes a look at Mounjaro at its various doses, and again, goes out to week 72. And here's the placebo arm that you'd actually gain or lose just a little tiny bit of weight. But if you take a look at all these other arms of different Mounjaro doses, you get anywhere from about a 16 to 23% relative weight loss. So again, dramatic data. That's quite good. You know, of course, we don't do this just to have people look better. We know that obesity is associated with all sorts of issues. And so, you know, this is a nice chart that kind of takes a look at, well, you know, how much weight loss would you have to need to see an improvement in some of the problems associated with obesity? And really, you start to see improvements in a lot of these things only at 5% weight loss. So if someone can just lose 5% of their body weight, they improve physical function, their blood sugars get better, hypertension gets better, and their damage to the liver gets better. But when you're starting to get numbers like Mounjaro's got 20%, you're basically completely blocking the development of type 2 diabetes. You're seeing dramatic improvements in physical function. You're seeing improvements in cardiovascular risk reduction and blood pressure. It dramatically increases the risk of developing sleep apnea, and it dramatically improves liver scores in patients with non-alcoholic fatty liver disease. So GLP-1s don't just work because and everyone's like, well, it just makes you not hungry. Yeah, that's part of it. It does trigger the satiety response in the brain, but it also has other effects as well, including it increases insulin secretion, it decreases apoptosis of cardiovascular cells, it decreases glucagon secretion, and it has anti-inflammatory properties as well. So it isn't just, you're not hungry anymore, and that's why you have all these other effects. The other thing that's almost certainly going to change the game here and will probably be out later on this year or early this year is the triple G drug. I think it's rizaperitide is the name, but Ozempic and semaglutide agents are just GLP-1 drugs. Mounjaro is a GLP-1 drug and glucagon co-agonist, but now we're going to have a GLP-1, GIP, and glucagon triagonist, and the data that they're getting in that is amazing. They're over 85% of people are losing 20% or more of their body weight. They're actually getting better results with rizaperitide than they're getting with weight loss surgery. And so that will probably be reserved for patients who are morbidly obese, because you've got a good shot at dropping 20 to 30% of their body weight with these medications. So some questions about these medications. Yes, there's been reports of long-term effects such as gastroparesis or pancreatitis. So far, those numbers have been very, very low. And again, I think in most patients who are obese, the benefit's is going to outweigh the risks associated with this. One issue anesthesiologists and surgeons have had has been perioperative management, because these drugs do slow down gastric emptying. The old nothing after midnight thing might not be enough in these patients. So now we're recommending to hold the drug 1 to 2 weeks prior to a procedure. Interestingly, one of the things that the GLP-1 drugs do besides satiety is decrease cravings. That's one of and the people I know who are on these drugs who have lost a lot of weight have told me that, most people pass a plate of chocolate chip cookies, we get one, right? It's a craving that we kind of satisfy. They don't have that anymore. It just looks like that's something. They have no craving for food whatsoever. And so now there are studies underway suggesting that these drugs may actually have as much benefit in alcohol use disorder and opioid use disorder as treatments for that as well, because it takes away those cravings as well. Because of the shortage of all these drugs that's been going on, as well as the incredibly high demand, many compounding pharmacies have now gone to making their own GLP-1 drugs. I would say, and like many med spas are opening up. We have a couple in Des Moines where basically you spend 5 seconds in front of a nurse practitioner and they have compounded semaglutide ready and waiting for you. I actually, for those of you who don't know, I have a podcast that I do. I actually had some people from the compounding PCCA, the Pharmacy Compounders of America, on, and they noted that if you have a prescription for a GLP-1 drug that has to be compounded, and it's a compounding pharmacy, it's licensed in the United States, they cannot get drug from overseas. They can only get drug from FDA inspected facilities. So they actually get their raw material from the exact same place that the drug companies do. So I would say that if you have a PCCA certified compounding pharmacy that is licensed in their state, you really don't have to worry about getting, drugs that aren't there. You don't know the right dose, anything along those lines. But what that means is that the onus is on the patient, because the med spas are going to tell you that. The onus is on the patient to figure out where are they getting that drug from and doing some research themselves to confirm that. So that's Gamechangers, only a minute over. A lot of information. Again, I always tell people focus on areas that impact your practice and those bottom line slides. And again, what are some game changers you see in your practice site? We're always open to taking requests if there's something you guys want to learn about. As I said, I have for now 4 years have a podcast called Gamechangers Podcast. If you go to where you get your podcast and look at CE Impact, which is a big CE company, CE Impact, look at that where you get your podcast and look for the Gamechangers Podcast and just go ahead and sign up for it. If you want CE for both physicians and pharmacists, we actually offer CE at very reasonable rates, where all you have to do is listen to me for a half an hour, go to the website, answer 2 questions, and you get your CE. It was pretty simple. Questions? I apologize for going a bit over, but a lot of information. Is there any way to tell if do they do questions? No?
Tim should be monitoring it.
Okay.
in the
Usually
office.
people will type them into the chat.
Okay.
There aren't any questions online.
Okay. Well, thank you very much.
Thank you.